Hello, everyone. Welcome to another VMR session with us. Today, I have this honor of being discussing with my friend Seyma that is joining us from Berlin. I would like to know what time is over there, Seyma, and thank you for accepting to co-discuss with me a great case by Dr. Ravi. Hey, Seyma.
Hi, my friend. Here in Germany, it's currently 6 p.m., so it's not 1 a.m., the usual time when I join. And I'm also so excited to discuss with you.
It's great to know. Hello, Dr. Ravi. We're waiting for your amazing case. Would you like to introduce yourself? I mean, you're very well known and dearest to us all. So maybe you can give us a little words of support.
Hello, everybody. I just want to say I'm very stoked to be able now to be on the other side and present a case today. So the pressure is on Yazmin and Seyma, but I have brought a very kind and a very instructive case for both of you today, and I'm just going to be sitting back in awe of both of your brilliance in discussing this case that I have today. So thank you for allowing me to be on this side and giving you this case today, and I think you're absolutely nailed this one. So back to you.
Thank you so much. I really appreciate this, and I'm very happy to have Seyma helping me today. So why don't we start our scribe depth? Okay, whenever you're ready.
Okay, my screen disappeared, but I'll give you the first aliquot. So for today's case, we have a 86-year-old female. She came into the emergency room and she's like, I am very tired, and I was able to take care of my activities of daily living. I clean my house and I take my dog out for a walk, but I've noticed that I've become very fatigued over the past 1 week. So about a week ago, I was able to do all these activities, but it's just slowed down over the last few days. And yesterday it was very difficult for me to just will myself to get up out of bed and move around. So I would just say 86-year-old female coming in with 1 week of fatigue for the scriber. I said a lot of words there, but I'll stop there.
Okay, do you want to start, Seyma, or should I start?
You can start.
Okay, for fatigue, it's a very, very broad complaint. It's very common, especially in primary care. We have to ask the patient if there's lifestyle issues. Very well, she can tell us that she has been feeling more fatigued while doing her daily activities. Now, should this be a secondary to any other medical condition? Could this be physiological? Could this be chronic? I think I would start by asking the onset how much time more, like if she has felt this way before. And I think that the first thing I would ask is if there are any other symptoms, second, like comorbidities or symptoms that are also presenting with fatigue, like what time. I would ask about the quality of sleep, first of all. Like, what time do you go to bed? Are you okay while awakening? Do you have any swelling? Do you have any or edema in lower limbs? Do you have any chest pain? Because with fatigue, as many other people in the chat are talking about, I will think, do you also have any complaint of chronic pain or chest pain, or try to point it, where is this going? Like, what are we talking about? If this patient may be having all cardiovascular symptoms, may have respiratory symptoms, may have joint pain, but that could take us to another place. So it's a very broad area where we should want to look for a secondary, like another thing, like fatigue plus something else. What do you think, Shane?
Amazing differentials. So when I think of fatigue, as you said, it's very unspecific. The most common things that I think of is like something like anemia or depression or any kind of thing that goes in with the systemic process, infection, malignancy, autoimmune, or any disease of the liver, heart, kidney. So, any kind of uremia or chronic heart failure can go in with fatigue, or any endocrine disease, as also Marino mentioned, like hypothyroidism can present with that, or also adrenal insufficiency. But without going much further into detail, I would wait for the next aliquot.
Amazing, amazing. I just love your mental model, how to sort of approach this. It is non-specific, as you mentioned. So a little bit more history. I think the chat had some questions. So yes, there is fatigue, and it is associated with exertional dyspnea. There's also palpitations when she's exerting herself, and some slight left-sided abdominal pain, which she's never had before. And she also reported that her urine has become dark over the past week. There were no fevers, no chest pain, no flu-like symptoms. Stool has been regular, and no bleeding that she knows of. I'm going to move into the past medical history. There is history of MGUS, high blood pressure, sleep apnea. She did have her screening tests, colonoscopy 6 years ago, and mammography. All of that was unremarkable. And nothing in the social family history, anything there that's relevant to the case. And I'll stop there if you'd like to elaborate on that.
Okay, so I would first tackle the dyspnea and the palpitations. As we know, the most common cause for dyspnea, if we tackle it, is the heart or a pulmonary cause. We can also think of anemia that can present with it, or any kind of acidosis. And the palpitations can be, the question is there, so we don't see that she had any kind of arrhythmia like AFib that can present with palpitations. Otherwise, any kind of chronic heart failure, like they can present with palpitations or tachycardia to compensate the low cardiac output. And now also seeing the dark urine. For dark urine, it's we can ask ourselves the question, some medications can present with dark urine, like, I don't know, rifampicin or some supplements. And otherwise, the question is it, are there erythrocytes, or is there something like myoglobin or hemoglobin in something like rhabdomyolysis or intravasal hemolysis like in PNH, or any kind of liver disease, so more intrahepatic or posthepatic, so with the direct bilirubin that can go into the urine, make it, you know, dark. And also glomerulonephritis or can present with dark urine, so it's still very broad. And also seeing the sleep apnea makes me also concerned, like complications of sleep apnea can present with something like pulmonary hypertension, also can present with secondary hypertension. They can also present with fatigue, because I feel due to the hypercardia they have, and also they usually present with morning fatigue. They didn't sleep very well, they're very tired. That can be caused. And the monoclonal gammopathy is still very unspecific. I know some older people can present with that, but we also know that sometimes MGUS can also be associated with some renal issues, like I feel like it was C3 nephropathy. But I don't want to go much further into detail. I would like to ask Yazmin.
I love listening to your differentials, Brian. I normally read them on the chat, all your pearls, but I'm totally with you there. When I'm listening to fatigue and I'm listening to this palpitations, chest pain, the first thing I would like to know, or like to dig more around, is maybe this could be a heart failure, and now listening to the past medical history of obstructive sleeping apnea, I will think, remember the complications of OSA would be systemic hypertension, hypoxia-induced cardiac arrhythmia. We can have pulmonary hypertension. We can have polycythemia because there is not enough oxygenation, so the body needs to compensate for that. There's higher risk for cardiac infarctions. So that's something that I will also want to look into, like the cardiac issues in this patient. I would definitely search for any like murmurs, if there are any, how is the pulse, Maybe we'll see the vitals, of course, but that would be my first, that I will put that in this bucket, the cardiac bucket. And again, I think that your DDX was amazing, friend. Why don't you give us a little bit more about the vitals and exam, Dr. Ravi?
Amazing, amazing. Both of you are doing so well. It's very difficult at this juncture what to really nitpick and really go into detail, what to go into, like what to invest your cognitive strategy on. So I think you're doing a very, very good job at this point. And you're at the juncture now of trying to generate your hypothesis. And as you get the history, you will then go into refining that hypothesis, then defining what is the ultimate hypothesis. So I think you're doing a fantastic job with what both of you are discussing. So the history definitely will move you along in this journey. So the temperature 36.3, heart rate 96, respiratory rate 20, blood pressure 156/77. She generally was not appearing to be in any distress. Skin, no rashes, and eyes, no icterus. Conjunctiva were pale, and the rest of the exam was normal. Let me see. Abdomen was soft, and there was tender splenomegaly. But otherwise, the rest of exam was normal. No murmur. Lungs were clear. So we can just cut to the chase and say it's normal, except for the splenomegaly and the anicteric sclera. Should we stop here?
Of course, of course. Now, for I would like to tackle this splenomegaly. Of course, like there is a whole big bucket of what could this happen, like liver disease, hematologic malignancies. We can have splenic congestion due to, if we're talking about my cardiac bucket, something that could converge in this Venn diagram, as Ibrahim taught us in an amazing meeting we had before. It's like, okay, so if I'm thinking something cardiac and this patient has a splenomegaly, something that can be in that convergence is the congestive heart failure, portal hypertension, and venous thrombosis can present with splenomegaly and can present with this chest pain, can present with this fatigue, exertional fatigue, this exertional dyspnea, sorry. And also, but also think, can this patient have an hemolytic anemia that could cause splenic sequestration? Can this patient also have any connective tissue disease that hasn't been found before? It's also infiltrative disorders such as sarcoidosis, amyloidosis. What else could it be? I think that would be my buckets in talking about splenomegaly. But again, there were no pulmonary, no crackles, no wheezing. So again, it kind of puzzles me, because I was thinking maybe this could be a congestive heart failure. But again, I think I would like to hear your opinions, Seyma.
I think you did an amazing job also how you tackled the splenomegaly. And as you said, the most common thing is portal hypertension. And then we have this great approach of thinking of blood, as you said, hemolysis, molecules like any kind of infiltration, like amyloid, sarcoid. And also what I wanted to mention, myeloproliferative diseases. And what was also mentioned, because it's a very elderly female, I've read in the chat people mentioning also CLL. But the thing is, what was mentioned for CLL, what I would expect is, since this is considered as a non-malignant, non-Hodgkin lymphoma, that it usually also presents with lymphadenopathy. And like if we see some signs like, thrombopenia, that would also maybe shift into that direction. But for sure, any kind of myeloproliferative disease can present with splenomegaly. So that's really concerning for me. And otherwise also thinking of tick-borne infections and also seeing the conjunctival pallor. One pearl that I once learned is like sometimes what can be very helpful for anemia is there's this so-called pallor rim sign. I don't know how to further explain it. You can Google it, but it's a very nice clinical sign for anemia. So at this point, I would be also worried for, especially with the dark urine, for some hepatic issue, like something like portal hypertension or renal issue that can go in with, low EPO production and renal anemia. So yeah.
I'm totally with you there, friend. Yeah, and we had a really good question in the chat that I think we should highlight here out loud. Dr. Austin is asking us, what do we think of the time curves of that? What do we think of this splenomegaly, if it could be subacute to chronic? And thinking about it, I remember that for splenomegaly, it could be congestive, infiltrative, immune, anaplastic. So for congestive, of course, by portal hypertension, infiltrative, like metastasis, myeloid neoplasms, like many people here in the chat have been mentioning, immune, such as endocarditis, sarcoidosis, rheumatoid arthritis, or neoplastic, such as lymphoma and other cancers. I think that all of them would have more chronic or subacute presentation. I don't think it would be sudden onset. So that would be more I would be more focused on looking around that. So, but to make this much more interesting, I will make some breakout rooms with all of you so we can all discuss it in groups. There you go. We'll have, okay. I think you already have it. Yeah, I think all of them are in. All of our friends here are in breakout rooms now.
Yeah, I think majority of, I mean, people can elect to join. So if anybody's hanging around, you're welcome to, but great job. Yeah.
Thank you.
Very good. I think there's quite a few questions I can't answer. It's not my case, so I can't tell.
Okay.
I didn't see this patient, but it was one of our morning reports by a resident. But yeah, I think the next aliquot will help you move along in the case in trying to refine your differential.
Yeah, like I really have, I am wondering also because cardio is one of my most feared areas. I don't feel that I'm very good in cardio. So that's why.
Yeah, as far as, well, cardio, the thing here, did we get any signal for cardiac disease though? What's interesting, you have palpitations, right?
Yeah, in the beginning, palpitation and exertional.
Palpitations could be indicative, yes. When you, I have a schema for palpitations, so you have to first define if there's pseudo palpitations or if the palpitations are due to just fast heart rate. Heart rate is 96, maybe it elevated to over 100. So a fast heart rate, it may not be an irregular heart rate. So here I mentioned regular, like a regular rate of rhythm. So you can have certain arrhythmias. The most common may be sinus tach, but you could have other narrow complex arrhythmias. You could have AVNRT, AVRT, junctional tachycardia, atrial tachycardia, so many kind of things. But here we're not dealing with an arrhythmia. We're dealing just with sinus tach.
Yeah.
Oh, Seyma disappeared too.
Yeah, Seyma went into a room. The thing is, I don't know if it by itself only gives 5 minutes or I have to take them out.
Oh, close, yeah, hit close rooms and it then counts down. It gives them a countdown clock.
Okay.
Probably like 15 seconds. So they can then wind down there.
They have been there 3 minutes, so I think I will hit the button in like 10 minutes more.
And it might be good to then just ask them like, okay, what do you discuss? What do you think? I don't know who's in each room. Maybe grab like one name from each of the rooms.
Yeah, I think I will. From room 1, I see Amanda and Hans. From room 2, Ashutosh. Room 3. And oh, Shayma's in room 4. So, oh, Reshma joined us today. She's really nice. Thank you. I saw your picture, Dr. Ravi, of the resident. Dr. Shishruta is now the chief resident this year.
Yes.
Okay, hello everyone. Hello back. Hello. Now, I would like to hear about what you discussed in your breakout rooms. In the first room, Amanda and Hans, whoever wants to talk about, like, what did you discuss in your breakout rooms, or anybody else who want to jump in?
So first of all, I mean, I don't know what the patient has, so I think it is very important to be open for everything. We were talking about a tender splenomegaly, which is very unusual for malignancies, but because the patient has an underlying disease of MGUS, I would put the malignancy still on the table. And then, of course, the tenderness was making us think about infections more than anything. So infections and autoimmune, and maybe the malignancy, because after all, the MGUS might cause the spleen to be filled with molecules such as proteins, amyloid, but this should be painless. And then we have the brown urine. So an autoimmune panel where we look for ANA and for other serum markers, maybe rule out lupus, and then investigate the liver for some hepatitis, so a liver panel. And a complete chemistry, including calcium, is what I would like to see because of MGUS.
Definitely, amazing thoughts. I will also want to see the calcium. In room 2, Ashutosh, would you like to share with us what your group discussed?
Yeah, sure. We had a really good discussion. Like Hans just said, we were also thinking about like this. Could this be something that is transforming to like a severe form of plasma dyscrasia, like multiple myeloma or Waldenstrom macroglobulinemia? And we were also worried about whether splenomegaly in that case would be tender or not. So organomegaly is a crucial part of the diagnosis, I suppose, in when MGUS transforms into multiple myeloma. And one of our viewer also mentioned about there is a possibility that it could have transformed to amyloidosis, and that's what's causing the organomegaly. And again, but we were not able to figure it out whether it will be tender or not at that point. So there's something that we will learn today.
Yeah, of course. Can't wait to hear it. Now, for room 3, Noah and Shunya, I don't know who wants to share with us.
Yeah, for breakout rooms, we talk about the differential diagnosis based on the splenomegaly schema that is shared on the CB Solver's website. So the common cause for it is portal hypertension, like cirrhosis, and like any kind of liver diseases that can cause the portal hypertension. But we don't have any clues for anything that is leading to the liver disease. Like we don't have any icterus. And when looking for the rare causes, other rare causes, we don't have any tribal history. We don't have any specific history that can lead to the any like hem-onc diseases, so we are like losing direction at this moment. So we needed any more like specific information for that. So
Great, thank you. For room 4, Aisha.
Hello. So our group, we talked about our top one would be hemolysis. We would need to see the lab results, and we were thinking hemolytic disease, especially because she's a little bit older. We don't know her. We don't know much of her background history. We don't know about her diet, her vitamins. So we were focused a lot on the hemolysis part, and there could be an aspect of malignancy involved as well. But yeah.
Thank you so much. And last for the room 5, Reshma, would you like to tell us what your room?
Yes. So we came up with 3 differentials. We had infective endocarditis and malignancy, plasma dyscrasias, and Abhi brought out a beautiful point pointing to infections, how MGUS can cause hypogammaglobulinemia, and that would put the patient at risk for infections. And so we thought we would order labs, and like we move with how the labs are pointing to, and we thought we might also do an electrophoresis to rule out sickle cell disease, and inflammation markers, CRP, ESR, and depending on the labs, if the labs point towards a malignancy, we might want to do an imaging to rule out malignancy, or if it's an infection, then we might want to be specific to rule out what kind of infection the patient has.
That is amazing thoughts, everyone. And yeah, definitely we will want to go and work through this cystic hypertrophy, something that we may think about so far. I think we all concluded that maybe a viral panel to see if this patient has EVB, hepatitis, HIV, bacterial, what type of bacteria can cause splenomegaly, tuberculosis, parasites such as malaria, babesiosis. Of course, this patient doesn't have this exposure risks. Other issues that we may think to this workup, we can think as room 1, 2, and 3 mentioned. Could this be a myelofibrosis process? Could this be an issue of excessive function of these normal spleen activities, or could this be a blockage of the blood flow through the splenic vasculature? So I think we can make this divide this to big buckets. Is my spleen working a lot, or is my spleen blocked? So that's how I like to see it. But let's hear about what else Dr. Ravi has to say.
All right, brilliant, everybody. I'm just amazed at the level of the discussion at this juncture, and to sort of give you a bit more information to get you on the right track. I think everybody's on the right track. So if I tell you now, white count 8.2, hemoglobin 5.3, hematocrit 17. MCV 129, platelets 178, chemistry sodium 138, potassium 5.1, creatinine 0.93, AST 73, and ALT is less than 9. And this is the first set of labs. And I'll stop there and also think about what would you like to order next?
Okay, so looking into the complete blood count, we have a very low hemoglobin. So she is anemic and the MCV is very high. So we have basically macrocytic anemia. And in order to tackle macrocytic anemia, we can ask ourselves, is it megaloblastic or not? Like megaloblastic with deficiency of folate, B12 deficiency, copper deficiency, but also myelodysplastic syndrome can present with it. And sometimes also any kind of hemolysis, what we all already discussed. it can present with macrocytic anemia, but also think of any kind of liver disease, or, you know, ASH can also present with macrocytic anemia. And now also looking that the AST is very high, which would make me rather think of increased cell turnover. So the probability of something like hemolysis is getting higher, because AST is not that specific for the liver, and seeing that the ALT is low doesn't make me really think of the liver right now. And otherwise, seeing that the platelets aren't really low and the white blood count aren't low, first, my initial thought was, okay, if we had something like bicytopenia, I was thinking of bone marrow process. But right now, seeing only the hemoglobin being affected, my key question would be, how long has she been this kind of anemic? Because if it's like acute anemia, whereas like 3 essential things we always have to think about, like bleeding, leukemia, or hemolysis. These are the 3 important things if I think of acute anemia. But if it's more chronic, there are some other buckets. But I would now give the mic to Yaz. What do you think?
Amazing, friend. And definitely, yes, these labs are putting me into the work hypertrophy of my spleen. My spleen is working up so much. And one of the issues, one of the 3 buckets inside of this one is RBC sequestration due to hemolysis. This patient has, we call it in Spanish, coluria. I think it's the same in English. And I might be think that this is an hemolytic process, or this patient also has this medical history of MGUS. So I would like to look more into, could this be a transient aplastic crisis that is causing my patient to have hemolysis, to have this macrocytic anemia, which can also present in aplastic, this B12. I would like to know the B12, obviously B9, answering to the question of Dr. Rabi, that could also present with megaloblastic anemia. So that would be my next step. Iron studies, B12, B9, and higher or further in the workup, I would like to know if bone marrow biopsy, depending on what we find in these studies. What do you think?
What I also wanted to add is, like what was also already mentioned in the chat, thinking of these autoimmune mediated hemolysis, since he has MGUS, we should, thinking of these Coombs mediated hemolysis. So we have this warm antibodies and these cold agglutinins. And I know for cold agglutinins, they can be known due to mycoplasma, EBV, but also secondary to any plasma cell dyscrasia, and also these worms. So I would like to test for it too.
Yeah, totally with you there. Especially with this MGUS past medical history, totally with you there. Maybe we should also look for do a step. That would be interesting. Blood smear, and of course, let's see what Dr. Rabi has for us now.
And that discussion is just on another level. You're both of you doing fantastic, and I think the chat's also on fire. So many points that are brought up, and I just love the teaching that we were all getting from the chat. I'm going to share my screen for a second, and I sent the labs to Deborah while we share screen. Are you able to stop sharing, Deborah? And then, right, okay. And you're able to see this. So for the labs, I'm going to give you some of these labs. Total bilirubin 5.7, direct bilirubin 0.6, LDH 847, haptoglobin less than 20, retic percent greater than 23. I don't have the retic index. We can calculate that. And kappa lambda ratio 0.22, so low, less than 0.26. So not something we're going to heavily consider. And a smear was done, so there were macrocytes, and then you have this configuration here of the RBCs, which can explain the large MCV, which are spherocytes. And that's the next aliquot before the last aliquot, which will give you the final DX.
You want to start, yes, or should I?
I'm thinking this could be very well like we spherocytes, but what do you think?
So basically about spherocytes in the context when they can be present, I mean, usually we think of something like spherocytosis, but in this context, also with the MGUS, rather of these autoimmune mediated hemolysis. So spherocytes can be present in IHA. So I would definitely, we haven't seen this kind of rouleau formation that was being mentioned in the chat, but I would like to do the direct and indirect Coombs test. So I feel like I feel like if we see C3 positive, I feel if it was cold that's for cold for the cold agglutinin type, and IgM, and IgG would be these warm antibodies. So that's, but what we already have seen is that there is really hemolysis ongoing. So we have to find out what is the cause of the hemolysis right here. What do you think?
I'm thinking that with this anemia and spherocytes, this patient, I really would like to know if we have B9 and B12 levels, and also think, well, what could this be if this patient was in a malnourished or was not, let's say, global south? I would think a megaloblastic crisis, which is due to folate deficiency, although it's very rare in patients in places that have access to nutritional to food. Let's say now I'm very interested also in knowing about this between cold IHA and warm IHA. Maybe we could see there are antibodies, but I'm really puzzled until now. There is like high bilirubin, high LDH, would make me think, what if this is another MGUS, like this patient has, or a myelofibrotic process? So I would really like to know if Dr. Rabi has more labs for us.
I want to add one more thing because about the dark urine. I have to say, at this moment, I would prioritize cold agglutinins because I feel like since also complement is being active there, we have intravascular hemolysis, and this can rather lead to dark urine, I would say. Yeah, but what do you say, Rabi?
Awesome. Very good. So Coombs test was done. So that's very important. And I don't know, Yazmin sat in on my anemia lecture, if you remember, when you rotated. Yeah. And what did I show for the hemolytic anemias? When you get the labs for hemolysis, the first thing you should do is the Coombs. So the Coombs for this is positive IgG. And I'll let you mull on that before I give you some more info.
I was wrong. So basically, we are confirmed. So I would think we can now confirm IHA secondary to warm antibodies. I am puzzled, but it was also already mentioned in the chat that this can also go in with extravascular hemolysis. And but what do you say, Yazmin, before speaking too much?
No, I was also thinking cold. I was even saying like cold in the chat. But yeah, I think that it is very important to see, like, we have reticulocytes, high reticulocytes. We do have haptoglobin, reduced haptoglobin, increased LDH, and this is total bilirubin 5.7 due to unconjugated bilirubin or indirect. We're saying here direct is not the high one, but the indirect one. All of these ones will tell us this is a hemolytic anemia, and now we're seeing this IgG. We're thinking, well, now this is a warm hemolytic anemia. So I would definitely want to know if there were any other antibody studies, but with this, we already know that this is warm. So, well, I think this would be warm. This pointing to me that we can think that maybe cold agglutinins, they will be negative, but of course, like we have the IgG. So what do you think? I'm very puzzled right now.
I'm also very puzzled right now. You know, for sure with this MGUS, there can be an association with the any kind of plasma cell dyscrasia, lymphoma can present with these autoimmune mediated hemolytic anemias. But I'm also very puzzled. So I'm asking myself whether any kind of imaging was done in this patient, and there was also, you know, several questions still regarding kind of lymphoma like CLL. So would like to see whether there's any whether any CT was done to look for any kind of, you know, lymphadenopathy within the body. So I don't know, retroperitoneal, yeah, or mediastinal. What do you think, Ravi?
I just love the deep discussion. Both of you are just very inquisitive and are looking for answers. But I think the answer is pretty much staring you in the face, and you were going down the right track of hematological disorders. So this patient does have MGUS, and it was interesting from this side to see how much people were trying to tease out of MGUS maybe the diagnosis here. But you're right, there is a connection. So you start thinking of MGUS associated disorders, like people were thinking hypogammaglobulinemia, and even the transition to multiple myeloma. So the yearly risk is about 1%. You can morph from MGUS to maybe Waldenstrom's or multiple myeloma. So you really do need to look at that as well. But going back to the spherocytes, so you will commonly encounter spherocytes with both cold and warm. And I think the process is usually these antibodies usually will then align around the RBCs. And there's this extravascular, which you are right, extravascular phagocytosis of these IgG-coated RBCs that just surround these red blood cells. And this happens in the spleen, so you will get mild splenomegaly due to this process. And then because of loss of RBC membrane, they become this globular round spherocytosis. I think also what you can sort of glean from this case is now to jump to the track of management reasoning. How would you manage this patient in real time? Yes, you got this diagnosis, patient's hemoglobin is very low. So now you need to start thinking about giving blood products. Patient's hemoglobin is less than 7, so blood products are necessary. Then what do you do to tamper this autoimmune mechanism? You can start steroids. And if in case the patient doesn't respond to steroids, then you may actually have to then escalate to maybe rituximab or immunomodulating agents. So you would need a hematology consult on board. Now, looking for maybe a leukemia or anything like that, if you do Google MGUS, you will see that there is an association. It's very rare, though. When I looked up just before this VMR, the association, there was a case that I had with Robbie about multiple myeloma with autoimmune hemolytic anemia, and it's very rare usually to have that was the cause of that was warm. Usually it's cold. So you are absolutely right that cold would be considered with this plasma cell dyscrasia, but in this case it was very odd. Again, I'm seeing for the second time a warm immune hemolytic anemia. So this autoantibodies that occur can be primary or secondary. We're not dealing with a primary autoimmune hemolytic anemia, we're dealing with a secondary. So secondary causes could be EBV, you mentioned HIV, somebody was mentioning HCV. Lupus is a common one. I usually do teach CLL, absolutely right. People were on that track, but unfortunately that wasn't the case. Multiple myeloma and MGUS. And as far as the diagnostics, you were right on the money with wanting the hemoglobin and CBC and then getting peripheral smear, Coombs testing, absolutely. Because if the Coombs test early on in trying to decipher the anemia, the hemolytic anemia, retic count was up, LDH and so on, everything was pointing in that direction. You want to rule out autoimmune hemolytic anemia, then jump to other causes such as RBC abnormalities, hemoglobinopathies, or even MAHA. So that was something that you would consider. But early on, you got the Coombs, then you can just invest all your cognitive energy into the domain of autoimmune hemolytic anemia, which both of you actually did early on. Then it's deciphering, is it warm or cold? That's okay. You want to get the antibodies, but you're right in that ballpark. And I want to applaud both of you for doing such a smashing job with this case. So how do you both feel with this case?
Oh wow, I feel this is stunning. I didn't think, because when you read about MGUS, it tells you it's even, I think the association, the ASH has said that it's the cold agglutinins. It's also associated with the poems that I think Seyma wrote in the chat, but mainly cold agglutinins, and it's the IgM, not IgG. So I was like, wow, this is something that just expanded my DDX. So thank you so much, and amazing pearls, everyone. It's so difficult to be talking and trying to read everything because it's so good what you're putting in the chat.
And also a huge thank you from my side. I think it was a very humbling case, and I had so much fun discussing with you, Yas, and also seeing the whole Pearl training in the chat. I also like this one Pearl mentioned, I think it was Dr. Austin, when we're talking about this very high MCV, that this is actually usually megaloblastic, unless I think there was it can be an artifact secondary to hemolysis in IHA, if I'm not wrong, but I still have to read everything in the comments. And last but not least, thank you so much, Dr. Ravi, for making this session possible and presenting this amazing case. We always learn so much.
Yeah, thank you so much. Now, should we go with Ibrahim with your teaching points?
Yeah, hello everyone. Thank you for this amazing case. So this was a case of a patient who had presented initially with fatigue. And if a patient is presenting to your clinic and they're complaining of fatigue, you typically have to ask about any associated medical conditions. You also have to ask about the chronicity, because the onset can clue you into whether this is bleeding versus leukemia versus hemolysis if it were acute, versus other differentials if it were otherwise. You also need to ask about associated symptoms, and those include quality of sleep, any swelling, chest pain, pinpoint pain, or any joint pain. For the differential diagnosis of fatigue, it's a pretty broad diagnosis, and it includes anemia, depression, infections, malignancy, autoimmune causes, uremia, congestive heart failure, as well as liver failure and endocrine causes, including hyper and hypothyroidism, plus adrenal insufficiency, as well as POEMs. Then we dissected each symptom that this patient presented with, and we tried to list a couple of differential diagnoses for each. So if a patient is presenting with dyspnea, you need to think about the heart and the respiratory system. You also need to think about anemia and acidosis. If palpitations, think about arrhythmia and congestive heart failure. If dark urine, think about rifampicin, myoglobinuria, paroxysmal nocturnal hemoglobinuria, as well as hepatic versus post-hepatic causes and glomerulonephritis. For fatigue, think about sleep apnea, pulmonary hypertension, as well as MDS, which this patient already had. For the physical, you want to look for murmurs and pulse if you're suspecting a cardiac cause. You also need to look for splenomegaly, which this patient had. If a patient is presenting with splenomegaly, think about congestion, portal hypertension, venous thrombosis, hemolytic anemias, connective tissue disorders, infiltrative diseases, myeloproliferative diseases, CLL, and finally tick-borne infections. For the orders for such a patient, you would typically order a CBC, a viral panel, serum protein electrophoresis, bone marrow biopsy, direct and indirect Coombs test, peripheral smear, and finally imaging. For the macrocytic anemia that this patient had, you have to think about megaloblastic versus non-megaloblastic macrocytic anemias. If it's megaloblastic, you need to think about folate, B12, and myeloproliferative disorders. If it were otherwise, you need to think about NASH, non-alcoholic steatohepatitis. You also have to keep in mind transient aplastic crisis and hemolytic anemias, whether it were due to IgG or IgM agglutinins. And you would typically consider plasma cell dyscrasias in cold IgM agglutinins. For the spherocytosis, the first thing you should think about in a patient who is presenting with this age, 86 years old, you need to think about immune hemolytic anemia. And you need to consider autoimmune causes, malignancies, HIV, lupus, HCV, and myelodysplasias. For this patient specifically, you need to think about management as well. So you'd start with a blood transfusion, and then you would start with steroids. And if steroids were ineffective, then at that point you would start with rituximab. So I think that's it for teaching points.
Thank you so much, Ibrahim, for your amazing teaching points. And thank you everyone for joining us today for another VMR. And have a great rest of your day or evening, and take care. See you next time.
Thank you, everyone. Bye.
Thank you.